in less than 10%, although we developed the transsphenoidal approach since more than now 40 years or 30 years. In 1979, I introduced the first transsphenoidal approach for pituitary adenoma, and we have made around more than 1,000 pituitary adenoma through this approach. But for the craniopharyngioma, I still prefer to use the intracranial approach, and you will see why. The second part of the presentation will be dedicated to the surgical results, mainly the long-term surgical results, because when you are operating craniopharyngiomas, you have absolutely to follow them for a long period of time if you want really to understand the real challenge of craniopharyngioma. Because as a benign tumor, they grow, they recur very slowly, and they need, of course, a long period of time to discover all these difficulties. Just some anatomical important remarks for the surgical approach. The origin and the site of the tumor. Either originally from embryologic or metaplastic origin, craniopharyngioma will start to grow in the majority of the cases alongside with the pituitary stalk. And you see that very quickly at the beginning, the first structure which is surrounded by the tumor is this pituitary stalk. And then the tumor will extend in different directions. It can extend anteriorly, as you see here. It can extend posteriorly. It can extend laterally, or it can extend above until the foramen of Monro and create such huge hydrocephalus, or come down, or unfortunately, very rarely come down to the sphenoid sinus. In our places, and due to the delay in the diagnosis, most of the patients came late, and we have a lot of large tumors, as you see here, extending in all directions. And of course, this is the real challenge for the surgical approach, and here where the intracranial approach is mandatory if we want to get all part of the tumor. And you see that in our series, for example, few cases, 22%, few patients have small or moderate size of tumors, less than 4 centimeters. Most of them, 41%, have a large craniopharyngioma, and also 37%, a larger part, have a giant craniopharyngioma. The third important anatomical remark is the vascular supply. Craniopharyngioma get its vascularization from the perforating arteries. Almost 100% of this vascularization coming from the A1, from the carotid artery, or from the bacon, either in one side or in two sides, depending on the extension. So you can imagine the difficulty of the dissection of these tumors and the respect of these perforating arteries. Fourth, the consistency of the tumor. They can, of course, grow as a single, large, or multiple cyst, or they can grow as a solid tumor, and both of them are calcified in the majority of the cases. And you see here in our series that less than 20% of the patients have a purely cystic tumors, 10%, or purely solid tumors, 8%. The majority, 80%, are cystic, solid, and calcified. The calcification are present in 70% of the cases. And one should pay attention to the appearance of these calcifications in MRI or in the CT scan. And especially when you have such thick capsule calcified, or these kind of stone-like calcifications, who are in general a signal to understand that you will have some and even a lot of difficulties to dissect such kind or such type of craniopharyngioma. And then the last anatomical remark is the anatomy of the ciliary region. And you see just here, just to mention, for example, here you have a long optic nerve with a post-fixed chiasm, a plenty of space between the interoptic nerve, laterally between the carotid artery and the optic nerve to remove, of course, the tumor. And we will see some examples. Whereas here, you have a prefixed chiasm, a very short optic nerve, no space here, no space laterally. So the only space is remained for you is to go through the lamina terminalis. In addition to all these factors, depending on the tumor, there are other factors depending on the patients or depending on the surgical team conditions, which of course are very important for craniopharyngioma surgery. And I would like to mention here three among these factors, which I think are the major features which, of course, govern the gross total resection of the tumor. And this is the case we have already seen, quite small tumor or medium size in young boy, 4 years, who came to see us just with for headache. And of course, this tumor can be removed through the transsphenoidal approach. But when I see it completely solid, and with more probability to be stuck into these structures, mainly the pituitary stalk and others, the chiasm, I felt more comfortable to operate through a transcranial approach. And you see here, this, it doesn't work. Sorry, maybe I can find it here. Yeah, you see here. I don't know what happened. It doesn't work. It's a pity. Anyway, the tumor is not large, as I said, and it can be when you make such a transcranial approach. Here we are on the right side. The optic nerve is here. And here is the capsula, which can be punctured, and then the dissection of the tumor from the chiasm, from the floor of the third ventricle is quite easy, and the tumor is removed completely, as you can see in this in the post-operative MRI, and the young boy is now 12 years, 8 years since he has a surgery, completely cured without any visual or hormonal or neurological deficit. Here the situation is different. Look, this also solid tumor, which is large, extending posteriorly, and you see the relationship with the neural structures surrounding the sella turcica. Of course, it was operated by right frontal lateral approach, as you see here, And look, the chiasm is almost completely destroyed here. And you see the tumor coming out from the lamina terminalis. You have here the I1 and here the middle cerebral artery, the carotid artery. And we start, of course, to remove slowly the tumor piece by piece. This part in general, completely solid, is adherent, and you try to dissect it and use either the anterior-optic space and the lamina terminalis space to remove step by step. And with this some smooth traction, the last postoperative control with a complete resection of the tumor. Now, sometimes, of course, the adherents are important. And you see that the part of the tumor is lived here in the floor of the third ventricle, as you see in the post-operative MRI. And it was treated with a gamma knife radiosurgery. And you see the disappearance, the complete disappearance of this remnant tumor 18 months later. Since we had our gamma knife unit in Rabat in 2008, we treat all our craniopharyngioma in completely removed or pituitary adenoma with a gamma knife radiosurgery. And you see here another case. It was a second recurrence. It was operated twice, and the recurrence was directly treated with radiosurgery. And you see here the complete disappearance 2 years later. We have reported previously our experience on gamma knife radiosurgery in pituitary adenoma and craniopharyngioma in this special number of not electa, sorry. It was a supplement of acta neurochirurgica. And you see here that the cover of this review is reporting the case we have in the. Now, when you have large tumors which are cystic, you can, in most of the cases, you can remove them because the capsula is in general thick, it's not calcified, and you can dissect them quite easily. You see here, after the protection of the optic nerve, here is also a right frontolateral approach. The cyst is being evacuated, and here the dissection of the capsula from different sides. You see here the arachnoid respected, and the capsula is resected, dissected from the pituitary stalk, from the floor of the third ventricle, from the chiasm, and it come out, as I said, with a small retraction quite easily. And you see here the control on MRI after surgery. Now, even if the tumor is cystic in its appearance and large, pay attention to the CT scan and MRI to see that there is some calcifications. As you see here, this like stone calcification, which is just below the chiasm. And of course, it was approached from the frontal, the left frontolateral approach. You see here the carotid artery from the left side, the chiasm, the optic nerve, this large cyst going to the posterior fossa, which was punctured and then evacuated. And you see that the capsula is not adherent in this peripontic cisterns, and it can be removed quite, again, easily. Just some smooth traction, and then to cut the first part of this capsula to remove it. But you see that the rest of the tumor and the capsula cannot come down, not come out, because it sticks to this large calcification, which is here below. And the trick I found in my experience with these like stone calcifications is to open the capsula surrounding the calcification, not to try to remove it with the capsula, to open it, to dissect the calcification inside the capsula. You see, the capsula should be opened quite widely, and then to dissect this calcification and to remove it alone. And then after the removal of the calcification, you will see that the rest of the capsula is coming out very, very easily. Here the calcification is removed, and now just to pull smoothly this calcification as it's not adherent, not invasive craniopharyngioma, it can be removed completely, although the tumor is large, as you see in the MRI. And here the tumor is completely removed, and you will see that the pituitary stalk is completely really respected here. And you have the post-operative control of these patients. These are the two last cases I am showing because they are the most difficult: large, giant, calcified, cystic, and solid. And these tumors are quite difficult to remove, and they are the most risky for morbidity and mortality after surgery. And most of these cases are removed subtotally or partially and should be treated, of course, with other adjuvant treatment. And you will see this case, the patients, the patients arrived quite late. She was already comatose, a young girl, 5 years, and she had a large hydrocephalus. We started by putting shunt in this ventricles, and fortunately, a week later, she improved very well, and she was operated. You see here again the frontolateral approach, right side, the protection of the optic nerve, and the tumor is coming outside here from the lamina terminalis, and of course, it's on the anterior optic area. We use these spaces to dissect look at the perforating arteries, and here we go to the lamina terminalis to continue the dissection. The tumor is adherent to the surrounding structures, so you have to try different tricks. And you see here one of these tricks is to push the tumor through the lamina terminalis to the anterior optic space, piece by piece, and to try to remove it. And then sometimes by chance, you will see that the last part, as in the previous case, is coming out alone because of this large cyst you have here. And the tumor was completely removed. And you see here the young girl 6 months later, but with a huge delay in the growth and severe endocrine disturbances. Now, pay really careful attention to these large tumors. You think that they are cystic because they have this appearance of cystic tumors in some on the MRI. And you see just here small video, you see that most are solid, as you see here. You have to cut them piece by piece, and you have to try to dissect them. They stuck to all the structures, to use sometimes the CUSA. And look here, we are on the lateral extension on a right temporal lobe. You see the tentorium, you see the third nerve, and you see that the arachnoid is invaded. The parenchyma also, and the dissection of such tumors is very, very difficult. You will see here how they're stacking how they're thick and the solid. You have to cut piece by piece. Look here, the internal carotid artery, the perforates, the bifurcation of carotid artery, the chiasm, And it's really such kind of tumor are really difficult to be removed completely. And as I said, these are the most risky for the post-operative complications. Here we have the total removal of the tumor in our series, and you see that this total removal, we had it in 47% of the patients. Subtotal with a really very small piece of the tumor, less than 10% in 25, and in 28% of the cases, we had, of course, a partial removal. There is complications in this surgery, still mortality in this surgery, unfortunately, due to different factors I have already mentioned. And you see that the hypothalamic complications are the most cause of this mortality. And of course, in the last years, we start to have patients coming quite earlier with more less size, less large tumors. And you see that in these 30 patients operated in the last 6 years, we had only one death, which give us just 3% of mortality. Other complications, mainly the diabetes insipidus, the neurological deficit in some cases, meningitis, and of course, some cases of visual deterioration. Now, the second part of my presentation is regarding this long-term surgical result. I think that one of the lessons I learned from this series of craniopharyngioma in this long period is when you read the literature, you have to pay attention to the series which report the follow-up with very limited follow-up. So limited value of the reported surgical results in craniopharyngioma in the literature when the follow-up is less minimum of 5%. Because, as I said already, these are benign tumor, they grow very slowly, and the recurrence, the regrowth came after many years follow-up. Two important issues in this long-term surgical results. First is the recurrence of the tumor, and second is the quality of life of the patients. So if we look to the recurrences, we see in this slides, we tried to gather here all patients who had recurrence, the first recurrence after the first surgery. And you see here the group of patients with partial removal, with subtotal removal, and with a total removal. In red, you have here the number of recurrences we had before 5 years. And in green, you have the recurrences we have after 10 or 15 years follow-up. And you see, for example, that in group of partial removals, of course, you have, and it's very known, 66% of recurrences before 5 years, 53% before 5 years, 66% after 10 years, and then all patients almost finish by having a recurrence. In the subtotal removals, in this group of 50 patients, you have, if your follow-up is less than 5 years, 2 years, 3 years, as we see in many papers, you have just 16% of recurrence. Whereas after 10, 15 years, you have 54% of recurrence in subtotal removal. And even in the total removal, if your evolution is less than 5 years, you have 0 recurrence. But after 5, 10 years, 15 years, you have recurrences even in these total removals, 7% recurrence. Regarding the quality of life, We try to apply this criteria, which were published by the group of Mayo Clinics in Charlottesville, well experienced in cellular tumors surgery. And they consider 8 criteria, as you see here, 1 point for each criteria. And we can divide the patients to 2 groups. Group A, patients with a good outcome, who have 8 criteria, just 6 in our city. And group B, patients with poor outcome, where 1 of the criteria is not valid. And of course, the problem mainly in our area is the follow-up, the long follow-up of the patients. And you see that from all the series, we succeeded to have a follow-up for more than 10 years, only for 79 patients. And if we divided them taking in consideration these criteria and the quality of life, we have the group A with 57 patients, 72%. And just to show you 2 cases, for example, this young boy, 12 years, which was operated in 2000 with this medium-sized tumor. And here you see the control of the patients, 18 years after the first surgery, no recurrence of the tumor, and the patient is doing very well, just a small delay on his growth. Here, a second case, a young girl operated at the age of 12. She was operated in 1986. At that time, as you see, the diagnosis was made on CT scan. We didn't have yet the MRI in our center in Rabat. She was operated with complete removal, and you see her here. She is 47 years. She's teacher. 35 years later after after surgery. Now the second group of patients with poor outcome, 22 cases. And I can just show you one or 2 cases. Here is a large solid tumor, which we succeed to remove completely. Here is the control. The patients improved the visual acuity, and the control 6 years or 7 years later, but the patients had a morbid obesity and severe endocrine disturbance with the compensation, with treatment, and of course with the follow-up almost every day. In this group of poor outcome, very important, 4 patients have already died at 11 years, at 12 years, at 13 years, at 14 years, and at 17 years. I would like just to show you 2 cases to see how this surgery is challenging when you see the patients year after year and you don't have any possibility to cure them. Here is a case of a young girl, 6 years, which was operated in 1999. She has this cystic tumor, and you see here the post-operative with almost total resection with small remnant, just subtotal resection. She will recur 3 times. She will had 3 recurrence, 3 surgery in 2005, 2008, and 2009, total 4 craniotomies. And then she came in 2009 with this large tumor, kind of mass stuck into all the area, no possibility to remove it, and we performed the gamma knife radiosurgery. Some improvement, but no change 3 years later. Start to regrow. And second gamma knife in 2012, but nothing can cure the tumor, and the patients will die at the age of 18 years, 14 years after the first surgery. Here, the last case, very interesting. The young man, 18 years, which was admitted in our center in December 2013 in emergency. He was comatose, Glasgow Coma scale of 9, bilateral mydriasis, swallowing trouble, and right complete hemiplegia. He came from another country, and we have looked to his file. We found that at the age of 3 years, in 1998, he has a general seizures with decrease in visual acuity, and the CT scan shows this craniopharyngioma, which was operated with a craniotomy in his country, and the result was an adamantomatous craniopharyngioma grade 1. He had in 2007 this cystic recurrence with hydrocephalus. They put shunt, the VP shunt in the ventricles. In 2010, he has a third, as you see here, the expansion of the cyst, and they put recum reservoir and the puncture of the recum reservoir in the cyst. And you see the CT scan we perform in emergency when he arrived to our center, the recurrence of this large cyst, but also of the tumor. So in emergency, we did just the evacuation of the cyst by a stereotactic way, and the patients improved. And look, the MRI after the evacuation of the cyst with this large tumor extending upward and completely calcified and solid. So as the patients improved, we perform, because we cannot do radiosurgery on this large mass. So we perform inter-hemispheric approach surgery, and we succeed to remove almost 2/3 of this tumor. And then 2 or 3 weeks later, we perform radiosurgery, gamma knife radiosurgery. The patients continue to improve, but never completely alert. He continued to be to worsen, and 2 months later, you see he came in a very bad clinical state, and the MRI shows a very nice result on the local tumor, but these tumors developed in all his brain. And I have to tell you that at the histology of this last surgery with the anterior-hemispheric approach showed us a malignant craniopharyngioma. And here we are, the tumor has a metastasis in all the brain, and we performed a stereotactic biopsy on this metastasis, and we confirmed that, of course, they came from the first tumor metastasis of malignant craniopharyngioma. We reviewed at that time the literature, and we found that these malignant craniopharyngioma are very rare. Just 28, 27 observations were published at that time. And no one of them has metastasis inside the brain. We know the metastasis from benign craniopharyngioma following the leptomeningeal way, but not from the malignant. And you see that, unfortunately, all these patients die after just some months of this stage of metastasis. So to conclude, I have to say that the craniopharyngioma is a still severe tumor and a great challenge for neurosurgeons. The most forbidden of the intracranial tumor was used to say Harvey Cushing. Craniopharyngioma are rare tumors. They should be managed by experienced multidisciplinary team in referral centers. The main parameter governing surgery are, of course, the tumor size, its consistency, its relationship with the cell region structures. Careful analysis of the MRI of these structures to understand this parameter before surgery is crucial. Radiosurgery is the best adjuvant treatment, and there is, of course, as I said, a very limited value of the result on the outcome after surgery of craniopharyngioma with the main follow-up of less than 5 or 10 years. Just to thank all the groups of my team, neurosurgeons, neuroradiologists, neuroanesthesiologists, neuroendocrinologists, and of course, neuropathologists. Without their collaboration, it's not easy to manage such complex and difficult tumors. And thank you for your attention.
Thank you very much, Professor Khamlichi, for this outstanding conference. And you make a very important remark regarding the importance of the follow-up to discuss the results. And I give to my co-moderator, Professor Mustarshid, to introduce our next speaker, Professor Schwartz.
Thank you, Professor Wahabi. Thank you, Professor Khamlichi, for your excellent high-level science about macrosurgical management of craniopharyngioma. So I think if you want, you can give the questions or discussion letters to compare or to study the questions which approach must be done. So we can take the Professor Schwartz if he's ready to go on, and the discussion, if you want, Professor Khamlichi, Professor Zabi, the discussion will be later.
Yes, yes. At the end. We can leave the discussion at the end. Yes.
Okay, okay. Now, Professor Schwartz, thank you for your participation, and thank you for accepting to share your experience and your skills about endonasal endoscopic surgery for craniopharyngioma. You are welcome, Professor Schwartz. Thank you very much for accepting and to participate in our meeting. Professor.
Yeah, I'm here. Can you all hear me?
Yeah. Yeah, very well.
Can you see my presentation?
Sure. Well, very well.
Perfect. So I just want to thank you all for inviting me to speak to the members of the Moroccan Neurosurgical Society. It's really an honor to be invited. And I hope to share a little bit of the work that we're doing here in New York City. We're all, united in our battle, not only against craniopharyngiomas, but also against coronavirus. So we're all sharing the same struggles, if you will, in both situations. One thing I want to say first, before we begin, the last presentation was really remarkable. And it's clear to me that the craniopharyngiomas that we're treating, the majority of the ones that we're treating in New York City are very different than the tumors that are being treated, or at least the ones that were treated. I guess over time it's gotten a little bit better in terms of the delay in presentation, because most of the tumors we see have a diameter that's less than 4 centimeters as opposed to greater than 4 centimeters. And obviously, if you have a giant multicystic tumor that's in multiple compartments, often those are best treated with a craniotomy. So I think because craniopharyngiomas present in such different ways, we're almost seeing a different disease in New York City and in the United States. So I'm going to talk about that as well. I have a few disclosures of companies that I consult for or work with. I also want to thank some of the students, fellows, and residents who have helped me put together a lot of the data that I'm going to present to you today. So I work out of Cornell, and we started doing minimally invasive endonasal surgery, first for pituitary tumors, and then meningiomas, craniopharyngiomas, chordomas, and other tumors. And we started roughly in 2003. So we now have 17 years of experience, and we're going to draw on that. This is what the operating room looks like. I'm usually operating here. I put the scope on a scope holder. We're working through the nostrils, and we have navigation and some screens, but we try to keep things as minimally invasive and minimal access as we can. So let's just talk about the concept of minimally invasive and minimal access neurosurgery. First of all, the first goal is for it to be less traumatic to the patient. We hope to have fewer complications. However, the procedures may take longer than removing a similar sized tumor through a craniotomy because you do have a more narrow working corridor. And the procedures may be more difficult and require a longer learning curve because you have to use longer instruments and, again, a smaller space in which to work. But the outcomes cannot be compromised. We're not trying to use a surgery that is minimally invasive but achieves a lesser result than you would get through a craniotomy. That would not be acceptable. And the concept of minimally invasive or minimal access neurosurgery has been widely adopted in other surgical fields. And there are multiple examples of the way that technology, new ways of thinking about surgery and tumors have really transformed other fields and replaced more maximally invasive or more invasive procedures with less invasive procedures. But not all cases can be done in a minimally invasive way. And what's important is case selection. You have to very carefully study your preoperative films and know the limitations of the approach, know what you can and cannot get out, understand what the goals are of your surgery to see if the goals can be achieved with a minimally invasive approach or not. And then you have to acquire the adequate technical expertise to do the operation. And that includes not just experience, but having the right instrumentation, because you need a whole new set of instruments in order to do these types of operations. And as we've learned, you have to have a plan for closure. And the closure is as important as removing the tumor and often can be difficult depending on what type of closure you are trying to do. So in first-line therapy, the first goal, of course, is to make a diagnosis, make sure you know whether your tumor is adamantinomatous versus papillary. We have two different subtypes. They have two different molecular characterizations, and that can make a difference afterwards. The second goal, of course, is to decompress the chiasm if the patient has lost vision. And then you want to try to, if you can, get the whole tumor out, obtain a gross total resection, and try to cure the patient if you can and preserve quality of life. And I also will talk a bit about quality of life as well. We did a look at some of the molecular biology of our history of craniopharyngiomas. And we all know that there are two different types. The papillary craniopharyngiomas have BRAF mutations, and the adamantinomatous craniopharyngiomas have beta-catenin mutations, and the BRAF mutated tumors may be amenable to chemotherapy, but we don't yet know what the role is of chemotherapy in the treatment of craniopharyngiomas, how effective it is long-term. That's still a subject of debate. But clearly the pediatric tumors are all adamantinomatous and the adult tumors are more papillary. We looked at a subgroup of just our BRAF mutated papillary craniopharyngiomas, and the majority of these are suprasellar tumors. They can be very different, as you see in the images below. They can actually be small, large, cystic, solid, but most of them are suprasellar, and none of them have calcification. So if you have a suprasellar tumor in an adult with no calcifications, it's very likely a papillary craniopharyngioma. And the argument has been made that maybe those should be pre-treated with medication to try to shrink them prior to surgery and or radiation, but that's still something that is being investigated. The other question, of course, is how do we treat adults with craniopharyngiomas, and do we treat them differently than children? And the answer is yes, for sure. It is more acceptable to offer and to achieve a subtotal resection in a child to avoid hypothalamic damage and the resulting cognitive, developmental, and body mass index consequences. So we tend to be a little less aggressive if we think a tumor has invaded the hypothalamus. The negative consequences of damaging the hypothalamus are much greater in our pediatric patients. However, I would argue that most of the literature and data on pediatric craniopharyngioma and outcome was from patients who had a craniotomy. And the results may be very different using endonasal approaches. And I'm going to show an example of that. So there are advantages to a craniotomy. Obviously, you get a wider exposure, a better lateral view. Some of the tumors that were shown in the first presentation, I too would do a craniotomy on if they're enormous, multicystic in several compartments of the brain. The downside is you have more retraction of the brain, a higher risk of seizure, risk of wound infection, more risk of optic nerve manipulation, and this can affect visual outcome. The endonasal approach has a better midline view. There's less optic nerve manipulation. There's no brain retraction. But the downside is you have a limited lateral view. There's a risk of CSF leak that's clearly higher than through a craniotomy. And you have new risks such as sinusitis or loss of olfaction. So we're going to talk about craniopharyngiomas that are mostly retrochiasmatic. They're not prechiasmatic. I'm not going to talk about meningioma surgery. That's a separate location, but one of the characteristics that defines one versus the other of these tumor types is the craniopharyngiomas tend to lie behind the chiasm. So the relevant anatomy, of course, is some of these go into the cell, in which case the cell has to be opened. Many of the ones we see, though, are purely supracellular, in which case we only open up a slight bit of bone on the top of the cella. We don't open up the whole cella. And then we open up the tuberculum. We don't have to take much of the planum because we're working below the optic chiasm. So there's no value in going very high unless you need to go above the chiasm, which is rarely the case. And then we do open the medial optical carotid recess in most of our craniopharyngiomas. So our bone opening can look like this. It could even be smaller than this on the top. And sometimes we have to open up the medial optic canals if the tumor is going into the optic canal. The key anatomy is the superior intercavernous sinus and the superior hypophyseal arteries. Because we're coming in from the front, we see these arteries right away. The advantage is you can see them, you can try to preserve them, but that is critical. There are multiple anastomoses of these superior hypophyseal arteries, so it is possible from time to time to take some small branches. However, you do not know which branches you can take and which you cannot. And sometimes if you take the wrong branch, you'll lead to guaranteed ischemia of the stalk, or you can get visual loss if you're taking an end artery going to the chiasm. So you have to be very careful with these small superior hypophyseal arteries. So craniopharyngiomas, as we've heard, present mostly with endocrinopathy and visual loss. The standard of care, of course, is the craniotomy, which you saw beautiful examples of in the prior talk with masterful surgical techniques. Here's a case I'm going to present. This is a large, solid craniopharyngioma. It's above the normal size cella, and the sphenoid sinus is not that well aerated, but yet I would argue that a tumor like this is a tumor that doesn't have giant lateral cysts, doesn't go into the middle fossa, is an excellent case for an extended endonasal approach. The downside of the craniotomy for tumors such as these is that you do have to work through these small corridors, and you're working around the normal anatomy, the optic nerve, the third nerve we see here, the carotid artery, the bifurcation. So it takes a long time. You have to be very delicate, and there is risk of manipulating the optic nerves or damaging the perforators in taking out those tumors. And as you saw in the prior talk, and this is from a textbook of Spetzler's, when you do a craniopharyngioma through a craniotomy, what you see is mostly the normal anatomy. You see the anatomy you want to preserve. You don't see the tumor as much, and you have to move that normal anatomy out of the way. Whereas if you come in from below, most of the normal anatomy is being pushed out of the way. And what you see is really the very structures you're trying to save. And you can get a beautiful view from below. This is after resection, but just showing the anatomy of the chiasm and the stalk, the mammillary bodies behind, and obviously the ACOM and A2s, recurrent arteries. And this just shows you the beautiful view you can get from below. So we do almost uniquely endonasal surgery. And the reason is that the tumors we see are not the same as the tumors that you see. So we're seeing mostly smaller tumors, less than 4 centimeters in diameter. And I'll show you the importance of that size of tumor in terms of the outcome that we can achieve. So here's an example of the case. We open up the sphenoid sinus. We open up the dura. We give intrathecal fluorescein, so the CSF is green. We're working above the pituitary gland is down here. And we open up this tumor that I showed you before. We can come right into the middle of the tumor, internally decompress the tumor. We have a very wide view of the tumor. We don't even see yet the optic nerves or the third nerve or the carotid. And once we take out the center of the tumor, we can carefully dissect our way around the capsule. We see the adhesions. We can cut them sharply using gentle bimanual suction. Here we're dissecting the tumor off the back of the chiasm, and we'll dissect it off the hypothalamus. You'll see we're dissecting it off the stalk. We try to preserve the pituitary stalk if we can. If we can achieve a gross total resection, if we need to sacrifice the stalk, we do. And then we can see the plane between the hypothalamus and the tumor. And that that view of the plane of dissection is better, I would argue, from below than from above. You can see the third nerve and the PCA there. And when we're done, we do a gasket seal and cover it with a nasoseptal flap and some glue. And I'll show you more detail of that. So post-operatively from below, we've gone up into the third ventricle. This is the nasoseptal flap. This is the med port from our gasket seal. You can see the normal gland, the stalk has been preserved. Here's the chiasm in the A2s. And you see a nice radiographic gross total resection from the front in a coronal view. Now, I'll talk to you also about long-term recurrence rates and outcomes. We've only been doing these cases for 15 years, as you know, or 17 years as opposed to 30 years. I'm a bit younger, and hopefully I'll have even longer follow-up in the next decade or two. But this is one of the great advantages in doing an endonasal approach is there's no retraction of the brain whatsoever. And you can see this is pre-op and this is 2 days post-op. The tumor's been completely removed. Again, it's the same tumor I showed you before with no flare signal in the brain. I like to show this case as a case that was sent to me by one of my colleagues. This patient had a similar sized tumor, had 2 prior craniotomies and radiation therapy, and the tumor still recurred. And what I want you to see is that the encephalomalacia from the brain retraction in this particular situation is severe. You can see the tumor has recurred in the medial optic canal, which we can get to endonasally. This image also shows you severe brain retraction injury, recurrent tumor underneath the chiasm. So the surgery we did endonasally, we opened up the sphenoid sinus. Here we're opening up the optic canal medially from below. The tumor, as you saw, was in the optic canal. So we'll open up the optic canal and then roll the tumor out from the optic nerve. It goes deep in the optic canal, but we can expose all of that. Here we're removing the tumor from the optic canal, and you can see we don't have to manipulate the nerve as much as remove the tumor from the nerve. And then when it's stuck, we obviously have to do sharp dissection with the scissors as you would from above. You can see the CSF is stained green with fluorescein. This is the optic chiasm medially, and we can sharply dissect the tumor off the nerve using very gentle bimanual surgical technique, just as we would from above. This just shows you post-operatively, the tumor has been removed from the canal, and this patient has not recurred. This is really the largest type of tumor that we would take out endonasally. And as you can see, it's still smaller than many of the cases you saw that were removed from a craniotomy. Again, this is pretty much the limit of what you could do, but it's a decent sized tumor. And post-operatively, you can see a near total resection. I think we left a little bit on the hypothalamus that, again, we would follow and treat with radiation if it started to grow back. So we also wrote up a series of patients. There's been some debate about whether you can take out tumors that are uniquely in the third ventricle. These are those third ventricular craniopharyngiomas that don't come down into the sella or don't present themselves. And so we found 10 of our patients, and we were able to achieve a gross total resection in 9 of those 10 patients with uniquely third ventricular craniopharyngiomas. And one of them had a near total resection, which was 98% of it was removed. We used our gasket seal technique, covered it with a nasoseptal flap and either a lumbar drain or an EVD. And we had 1 CSF leak in a very obese patient, and that required a revision. And of course, these patients, many of them had anterior and posterior pituitary dysfunction, 90% and 70%. But we would argue that even if the tumor is in the third ventricle, it's not a contraindication for surgery. We also looked at the what we call the CPC, or the corridor between the optic chiasm and the pituitary gland. So it's the chiasmal pituitary corridor, which is this size, because most of these surgeries are being done in this corridor between the chiasm and between the pituitary gland. And the average size of that was only 10 millimeters. And we asked the question, if it's smaller or larger, does that affect our ability to achieve a gross total resection? And the answer was no. The CPC value had no relationship to our ability to achieve gross total resection and no effect on visual and endocrine outcomes. So if it is small, and this is a fairly small size, you can gently elevate the chiasm, which means you have to remove the bone above the chiasm a little bit, elevate the chiasm and work underneath it. You can also push down on the pituitary gland, which is why we remove some of the bone over the pituitary gland in order to increase that corridor to get up into the tumor. But this is the long axis of the tumor that we're working down. So how effective is endonasal surgery compared to transcranial? Well, we did an initial review of the literature, and there's definitely problems with doing reviews of the literature. And I'll talk about the problem with this data, but we're comparing the reports of craniotomy, which is open transcranial for craniopharyngioma versus endonasal versus transsphenoidal microscopic. You can see a higher rate of gross total resection in the endonasal cases. However, there's no question these are smaller tumors than the open transcranial tumors, as we saw. So this is not really a legitimate or fair comparison. Also, we reported better visual outcome using an endonasal approach versus a craniotomy. But again, these tumors may be much larger, much more extensive, but it led us to believe that visual outcomes may be better when coming from below. We then re-examined the literature. We published this in the Journal of Neurosurgery. If you look at the gross total resection rates with transcranial surgery, it's anywhere from 40 to 90%, 4% CSF leak rate, visual improvement 0 to 47%. In the early endonasal surgery literature, the gross total resection rates were similar, CSF leak rates much higher, visual improvement a little bit better. And if you look at the later literature, the gross total resection rates went up. This could obviously be from case selection, selecting smaller tumors for endonasal surgery. CSF leak rates went down to 3% in some centers, and visual improvement went up. And so what we would argue is in well-selected cases, if you can choose your cases correctly, small tumors less than 4 centimeters, your results may be better doing them endonasally than through a craniotomy. Now, the only way to really show this is to compare tumors that are exactly the same size. You have to compare the same group of tumors done either endonasally or through a craniotomy, and that's very difficult to do. But we tried to do it at Cornell. What we did was we looked at 106 craniopharyngiomas removed at our institution, and we sent pictures of them on slides to 4 experts who were blinded as to whether the tumors were removed endonasally or whether they were removed through a craniotomy. And they chose out only the tumors that could be equally well removed through endonasal or craniotomy. So we're looking at the same size tumor for all the cases. And of those 26 cases where they said these could be removed either through a craniotomy or endonasally, 21 were removed endonasally and 5 were removed through a craniotomy. And we looked at the results of those cases, and we found that gross total resection rate was higher in the endonasal cases than in the transcranial cases. We found that there was no flare signal in the brain in the endonasal cases, and there was a large flare signal in the brain indicating some brain retraction and injury in the cranial cases. The endonasal cases, 2 required radiation, whereas most of them required it for transcranial. None of the endonasals recurred, and 60% of the transcranials did recur. In terms of vision, it was improved in 10 of the endonasals and in none of the transcranial cases. We had no cognitive issues after the endonasal surgeries, and we had a high rate after transcranial surgery. And of course, we did have a CSF leak after the endonasal case, which we did not see after the craniotomy. We've done about 135 patients so far. And again, the average diameter is 3 centimeters, right? We're talking about smaller tumors. That's average. We do some larger ones as well. Intended gross total resection, we get a gross total resection about 86% of the time in these tumors, and we get more than 95% of the tumor out about 95% of the time. Very high visual improvements rates, pretty low CSF leak with our gasket seal, and very low mortality rates. So some of the questions that remain: is the outcome much worse for reoperations than first-time operations? Sometimes we see tumors that have recurred. We need to deal with those. Do we sacrifice the stalk to achieve a cure? Is that worth it? How often is pituitary function preserved if the stalk is not sacrificed and you get a subtotal resection? Can you really preserve pituitary function? How often is that successful, leaving tumor behind? And then we'll talk again about the long-term recurrence rate after gross total resection versus subtotal resection plus radiation. So technically, I just want to show you a little bit about the gasket seal. We started out using fascia lata, and we would make it slightly bigger than the opening, the small defect, and we would wedge in a piece of bone. The reason why this works so well for craniopharyngiomas in particular is that the optic nerves, the optic canal is often not opened in craniopharyngiomas, so we can wedge in a piece of bone without risking damage to the optic nerve. We now do this gasket seal with a piece of Medpor instead of Vomer. We cover it with a nasal septal flap and then some glue. We've also moved on, and now we, instead of using fascia lata, use acellular dermal matrix so we can get it off the shelf. And that saves the patient from having an incision in their thigh. We're trying to do minimally invasive surgery. We don't want to make more incisions. So we looked at 19 patients, all had high flow leaks from meningioma, craniopharyngioma, chordoma. We did 16 gasket seals, 3 had button closures, where mostly in the meningiomas where we didn't want to risk damaging the optic nerves. There was only 1 leak, and we compared it to 19 historical controls who got fascia lata where there were 2 leaks. So the leak rate was about the same. And so now we've switched over to acellular dermal matrix and don't use fascia lata anymore. With regards to reoperations, we compared 35 first-time operations with 22 reoperations to look at the results in a consecutive series of patients. The volume of the tumors were the same, and the gross total resection rates were roughly the same, 90% in the first operations and 80% in the reoperations, slightly lower, but not that much lower. Visual improvement was about the same. We found that new anterior pituitary deficits were more common in first-time operations compared with reoperations, but new DI was more common in reoperations compared with first-time operations. So let's talk about stalk preservation. If you sacrifice the stalk, is DI inevitable? Does sacrificing the stalk increase your chance of cure? If you preserve the stalk, will you preserve pituitary function? At what rate? And if you preserve the stalk, achieve gross total resection, will you sacrifice your cure rate by leaving some microscopic residual that perhaps you're not aware of? So we looked at a large series of cases. We divided them into those in which we did a gross total resection. But we had to sacrifice the stalk. Those that had a gross total resection, this is on post-op MRI, gross total resection, but we were able to preserve the stalk. And then those in which we decided to do a subtotal resection or near total resection or couldn't take it all out, or we elected to do that in order to try to save pituitary function. And then we looked at how the patients did. So if you sacrifice the stalk, you get 100% anterior pituitary insufficiency. But if you preserve the stalk with a gross total resection, you can preserve pituitary function about 1/3 of the time. So that's worth it, assuming you're not getting higher recurrence rates. Now, what's interesting is that if you intentionally do a subtotal resection or near total resection with the idea of trying to preserve anterior pituitary function, you're not going to be very successful. So we had just as many people lose anterior pituitary function as did where we preserved the stalk and got a gross total resection. In addition, DI was found in the majority of patients who we sacrificed the stalk. We had 1 patient where we sacrificed the stalk, who did not go into DI. If you can preserve the stalk and obtain a gross total resection, you can prevent patients from going into DI about 50% of the time. So there's value in that. However, if you do an intentional subtotal resection with the idea of trying to prevent DI, you're not going to be very successful. A lot of these patients will end up in DI anyway. So how do these different strategies affect recurrence? Well, the lowest recurrence rate was if you do a gross total resection, you sacrifice the stalk. We had only 1 patient who recurred. If we did a gross total resection to preserve the stalk, we had a slightly higher rate of radiographic progression, but not that much higher. And again, these patients did preserve some function. And then if we did a subtotal resection, well, most of them would progress after that. We don't define that as recurrence because there's already tumor left behind. And then those patients who progress or recur get radiation. Sorry, these are just highlighting those results. So the end result of our experience is that if you can achieve a gross total resection and the patient has recurred, it's better to offer a reoperation before you give radiation therapy. If you cannot achieve a gross total resection, then I would give radiation therapy unless you need to improve vision, in which case you have to do surgery to decompress the chiasm. So what about long-term outcome? So we looked at our patients who we were able to follow for greater than 3 years follow-up after surgery. These were 44 patients with a mean follow-up of 5.7 plus or minus 2.6 years. Actually, you know what? I'm going to exit out of this talk. I have a feeling, I apologize for this. I just want to make sure that I'm giving the right talk. Let me just check something. Yeah, no, this looks good. Okay, I had made some changes. So let's look at long-term outcomes. So we have craniopharyngiomas here that have greater than 3 years of follow-up after surgery. 44 of our patients have a follow-up of 5.7 years. Now, as we heard from the last talk, even that may not be adequate, so we may have to revisit this question. Gross total resection was achieved in 77.3% of patients. 89.5% gross total resection was achieved in those in whom it was the goal of surgery. So the average tumor volume in the patients where we got a gross total resection was about 4 cubic centimeters, and those in which we got a subtotal resection, this is, was 4 cubic centimeters and 18 cubic centimeters in the ones in which we didn't. And if you look at, here's the number of patients in whom we got a gross total resection with. This is, again, this is tumor volume. This is not diameter. So if you have a preoperative tumor volume less than 10 cubic centimeters, you're more likely to get a gross total. We got a 90% gross total resection rate in those patients. And if you have a tumor volume that's greater than 10 cubic centimeters, we only got a gross total resection rate in 25%. So it just shows you that your chances of getting a gross total resection are much greater if you have a less than 10 cubic centimeters volume of your tumor. So in those that we did a gross total resection on, only one of those patients got radiation. And in those who we did a subtotal resection on, 70% got radiation. So we can compare them. And it turns out the 5-year recurrence or progression-free survival was 75% if you did a gross total resection. But if you did a subtotal resection, even though most got radiation, you had a 25% recurrence or progression-free survival. Many of those recurred. And the time to recurrence was much longer in the gross total resection than the subtotal, even when they got radiation. So these are those survival analysis curves. Some of them we did follow out to 10 to 15 years. And you can see that patients who had a gross total resection had less recurrence compared to those that had subtotal resection. And again, the majority of these got radiation, and even in spite of radiation, they did recur. Now, in order to take out the confounding fact that one of these patients with a gross total resection had radiation, and 3 of these patients with a subtotal resection did not have radiation, we narrowed down what we were looking at, the categories. So these are the patients who had gross total resection but did not receive any radiation, showing you their long-term progression-free survival. And these are the patients who had a subtotal resection, and all of these got radiation right away. They all had early radiation. And in spite of that early radiation, many of them progressed. So this is an indication to us that the strategy of gross total resection, when it can be achieved, is better at preserving a long-term recurrence-free survival. What about other outcomes? Well, those that we did a gross total resection rate had a lower rate of visual deterioration compared to those who had a subtotal resection. Now, remember, these are larger tumors. They're more stuck, perhaps to the chiasm and the hypothalamus. So that may explain it. There may have been more manipulation. Also, higher return to work and school for those in which we got a gross total resection. But again, these are selected for smaller tumors. We had no CSF leaks in our gross total resection patients. We actually had a 30% CSF leak in the subtotally resected tumors. These probably had a bigger bone opening because they were subtotally resected. And however, a higher rate of DI, as we showed in the gross total resections versus the subtotal resections. What about pediatric cases? So in this series of patients, we operated on patients who were less than 18 years old. We recorded 11 patients. We were able to get a 50% gross total resection rate. We did, in the other half, selectively do a near total resection or subtotal resection or biopsy to avoid hypothalamic injury. Anterior pituitary dysfunction was in 81% and DI in 63%. Only 2 patients, however, had an increase in BMI greater than 9%. And this happens pretty quickly. So you don't need a lot of follow-up to measure their BMI outcome. Visual and function was stable or improved in 73%. All of the children returned to an academic environment 10 of them in grade appropriate. So that's the vast majority, or actually went back into their same grade.